This lecture is on Chapter 16, Quantitative and Qualitative Platelet Disorders. At the end of this lecture, the student will be able to define quantitative platelet disorders, identify the types of bleeding that are seen in platelet disorders, differentiate platelet abnormalities that are due to acquired defects, drug-induced, non-immune, or vascular-related, state how pre-analytical variables may affect the platelet count, describe three characteristics of the qualitative platelet disorders: von Willebrand disease, Bernard-Soulier syndrome, and Glanzmann thrombobasthemia. Identify drugs that are implicated in immune thrombocytopenia. Evaluate conditions that may cause thrombocytosis. Compare and contrast acute versus chronic idiopathic thrombocytopenic purpura in regard to pathophysiology, clinical symptoms, and treatment. Define hemolytic uremic syndrome in terms of pathophysiology, key clinical features, and patient management. Define thrombotic thrombocytopenic purpura in terms of pathophysiology, key clinical features, and severity. In order to look at quantitative disorders of platelets, we need to be mindful of what a normal platelet count is. As in the lecture for chapter 15, we talk about what a normal platelet count should be on a CBC or complete blood count, and that's 150 to 450,000. If a patient has thrombocytosis, that means there is an increase in their platelet count, and the platelet count would be greater than 450,000. Thrombocytopenia would be when a patient has a platelet count that is less than 100,000. And patients that have platelet counts that are in the 40 to 60,000 range may have bleeding unexpectedly during surgery or any type of injury. If a patient has thrombocytopenia and has a platelet count less than 10,000, they may experience or demonstrate certain symptoms such as gingival bleeding, which is your gums bleeding, epistaxis, which is nose bleeding, ecchymosis, which means you have excessive bruising, bleeding in the CNS or central nervous system, and also hemorrhage, which is a term used to describe blood loss. Thrombocytopenia related to sample integrity and pre-analytical variables. So when a coagulation sample is drawn, it's drawn in a light blue or Carolina blue top tube, which I mentioned in the previous lecture, and the anticoagulant in that is 3.2% sodium citrate. And how that works is that it binds calcium in a 9-to-1 ratio of blood to anticoagulant. So in order to make sure you reach this ratio of 9-to-1, there's a fill line, excuse me, on the side of the tube where the phlebotomist or the nurse or even a tech, whoever's drawing the blood, knows that they must get enough blood to reach that fill line in order to reach that 9-to-1 ratio. So it's approximately 90% full of that tube to achieve that correct ratio. You also want to make sure the tube has been mixed properly. Once the blood is drawn, it should be gently rocked back and forth to help. Now, if that ratio has been met, you want to make sure that it's mixed as thoroughly as possible. When it comes to what you can see on the differential smear, if that's needed for a CBC, if there's platelet satellitism seen in the peripheral smear, you can recollect the CBC in an EDTA sample tube, which is the lavender or purple top tube, and you multiply the platelet count by 1.11 to correct for the additional volume. Here is an example of what a differential slide from a CBC would look like. You can see there are some neutrophils, or the larger cells, or the white blood cells here, 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 and here. And these smaller round things around it, I don't want to call it a cell because platelets are not a cell. You can see the platelets are surrounding those white blood cells. So when we say platelet satellitism, this is what we're actually referring to here. A patient may have thrombocytopenia and it's related to actually a decreased production of the platelets. So you might have issues with the bone marrow function, a lack of platelet and the bone marrow aplasia. So you would have a lack of the megakaryocytes, which is where the platelets come from. Patients may have leukemia or other megaloblastic conditions. It could be contributed to cytotoxic agents, which means agents that kill cells, or some type of chemotherapy. It can also be related to particular bacterial infections. The patient may have an infection with a viral agent such as CMV, which is cytomegalovirus, Epstein-Barr virus, hepatitis C virus, HIV, human immunodeficiency virus, varicella, which is chickenpox, or rubella, which is the German measles. A patient may also have thrombocytopenia, and it's related to the altered distribution of the platelets. So as we've talked about before, the spleen holds 1/3 of our platelet volume. An enlarged spleen may draw in more platelets. This may be due to a myeloproliferative disorder, extramedullary hematopoiesis, which we've talked about in previous lectures, or even a hemolytic anemia. A splenectomy or the removal of the spleen may cause thrombotic problems due to more platelets are occurring in circulation in the peripheral blood. A massive transfusion can also cause coagulation factors to become more diluted and affected as well. A patient may also exhibit thrombocytopenia due to drug-induced situations or drug-induced thrombocytopenia. Different drugs that can affect this are the quinines, NSAIDs, which is non-steroidal anti-inflammatory drugs, such as ibuprofen or naproxen, heparin, which is an anticoagulant and anticonvulsant medication, sulfonamides, diuretics, which are drugs that are given to pull fluid off of the body, such as Lasix, or amoxicillin, which is a very common type of antibiotic. Some patients may exhibit thrombocytopenia due to an antibody formation. You can have a post-transfusion purpura or PTP, so an antibody to the platelet products containing HPA-1A, HPA-5, and HPA-15. There's also neonatal alloimmune thrombocytopenia, or NATE, where the maternal antibody to the infant's platelets from an earlier pregnancy. There's also idiopathic thrombocytopenic purpura, or ITP, where there is an autoantibody which is created with IgG against GP2B or 3A or GPB9. This condition can be chronic. The platelet count is 30 to 60 multiplied by 10 to the 9th per liter. It usually occurs in patients ages 20 to 50 years of age. The duration for this issue could be months to years. Common symptoms with this are splenomegaly, meaning the spleen is enlarged, petechia, purpura, epistaxis, which is nosebleeds, and ecchymosis, which means you're bruised very easily. Treatment for this condition can be prednisone, which is a steroid, anti-CD20, and rituximab. ITP can also be an acute situation, meaning it doesn't last as long. It affects a younger age group, so as it presents in the lab, the platelet count can be as low as 20 multiplied by 10 to the 9th per liter. Clinical presentation could include bruising, petechiae or nosebleeds, It usually affects those between the ages of 2 to 6 years old. It is often caused by a virus and lasts 2 to 6 weeks. Treatments are, or treatment options rather, are IVIG, Winrow, anti-D immune globulin, splenectomy, meaning the spleen is removed, or a platelet transfusion. Another type of thrombocytopenia related to consumption of platelets is TTP, or thrombotic thrombocytopenic purpura. It can occur in patients with SLE or lupus, a previous viral infection, or gastric carcinomas or gastric cancers. The platelet count can be less than 20 multiplied by 10 to the ninth per liter. The PT and the PTT are within reference range, so they are not abnormal. It can be tied to a deficiency of protein ADAMTS13. This protein normally cleaves the von Willebrand factor into smaller protein. If this is absent, if the ADAMTS13 is absent, this may cause excessive platelet clots. TTP clinical symptoms may include microangiopathic anemia or MHA, thrombocytopenia, fever, neurological symptoms, visual impairment or having issues with your vision, or renal dysfunction. Renal is the other word for kidney, so kidney dysfunction. Other clinical findings may be schistocytes seen on the CBC differential slide when examining the red blood cells, as well as severe anemia, and increased LDH, which is your lactate dehydrogenase, which is an indicator for tissue destruction or tissues being broken down. Decreased haptoglobin. Haptoglobin is the protein made by our liver to get rid of the hemoglobin outside of your red blood cells. Hemoglobinuria, which means there's an increase in hemoglobin in your urine, and also renal dysfunction may also occur. Treatment for TTP is corticosteroids and plasma exchange, which needs to be cryopoor in order for that to be a treatment. Another condition related to the consumption of platelets is hemolytic uremic syndrome, or HUS. It usually affects ages 6 months to 4 years of age. It mimics the TTP, but there are no neurological symptoms. It's more of severe renal damage. The renal damage is caused by a toxin that's produced by E. coli 0157 or Shigella, which is another type of bacteria, a GI pathogen. Patients may present with bloody diarrhea, vomiting, thrombocytopenia, and renal failure. Patients with hemolytic uremic syndrome may also present with fever, abdominal pain, the microangiopathic anemia with schistocytes seen on the smear. The toxin leads to cell death, especially in the kidneys. When it comes to whether or not they've been exposed to E. coli 0157 or EHEC or Shigella. Treatments for this include the anti-C5 antibodies and the anti-Shiga toxin, which is what is released by the Shigella bacteria. Thrombocytosis means there is an increase in the amount of platelets, so the platelet count is going to be greater than what is our normal range of 150 to 450. So the platelet count is going to be greater than 450 multiplied by 10 to the ninth per liter. The primary reason for thrombocytosis may be some type of myeloproliferative disorder. Secondary issue could be acute and chronic blood loss, chronic inflammatory disease, post-splenectomy. Again, that's when the spleen has been removed, as well as iron deficiency anemia, or IDA. And normally the actual function of the platelet is normal. We also have conditions where there is an inherited qualitative disorder of platelets, which means the actual platelet function is impaired. It's usually secondary to an intrinsic defect of the platelets. It may be a disorder of adhesion and platelet release or storage pool defects. Disorders of adhesion, we have von Willebrand disease, Bernard-Soulier syndrome, and Glanzmann's thromboplasthenia. Other issues with inherited qualitative disorder of platelets, we have issues where the platelet release defects. We have Hermansky-Pudlak syndrome, Shidakagashi syndrome, Wiskott-Aldrich syndrome, thrombocytopenia with absent radii or TAR, and we also have gray platelet syndrome. With von Willebrand's disease, it is an autosomal dominant defect. The pathophysiology can be qualitative or quantitative as far as its defect in the von Willebrand factor. Symptoms include bruising easily, nosebleeds, heavy menses or heavy menstrual cycles, excessive bleeding after tooth extraction or any type of dental procedures. The von Willebrand factor is carried into peripheral circulation by factor VIII. The von Willebrand factor is an intermediator for platelet adhesion and is a receptor for GP1B, GP2B, and GP3A. Three primary levels of von Willebrand's disease are type 1, type 2, and type 3. There are 4 subtypes of type 2 von Willebrand's disease: 2A, 2B, 2M, and 2N. The von Willebrand factor protein is measured by assessing the role in adhesion, assessing its secondary role in aggregation, and assessing the role in the clotting factor activity. And the ristocetin cofactor activity is the best predictive assay for when we're looking at how to measure these. Here is a chart that breaks down the 3 types of von Willebrand disease. So you can see the frequency for type 1 is 70 to 80%, type 2 15 to 20%. We don't even have a percentage on type 3. All we see is that it is rare. Type 1 is autosomal dominant, as well as type 2, with type 3 being autosomal recessive. The PT is going to be increased with type 1. It's going to be normal with type 2. And the secondary von Willebrand variants include types 2A, 2B, 2M, and 2N, which have not been discussed. And this gives the von Willebrand factor multiplier analyses as reference tests. When it comes to testing for von Willebrand's disease, you need a platelet count, and that's measured by our automated methods, meaning some sort of instrumentation. The PTT measures the anticoagulant portion of the factor VIII molecule. The F8C measures the clotting portion of factor VIII. The von Willebrand's factor RCO measures the function of the von Willebrand's factor activity by ristocetin-induced platelet aggregation, or RIPA. And the von Willebrand's factor antigen measures the amount of circulating protein but does not capture the function of the protein. So when it comes to a patient who has been diagnosed with von Willebrand's disease, the treatment is tailored to the type or subtype that the patient has. One treatment can be desmopressin acetate, or DDAVP, which is an injectable medication, or it can be administered via nasal spray. Also, another treatment option is high purity factor VIII products that can be given to the patient. The Bernard-Soulier syndrome is autosomal recessive. It's a rare adhesion defect of platelets involving the GP1B9 complex. So this complex is the site for thrombin binding, regulating platelet shape, and regulating reactivity. Clinical symptoms for Bernard-Sollier syndrome are epistaxis, gingival bleeding, as we mentioned before, is gum bleeding, menorrhagia, purpura, thrombocytopenia with giant platelets, ristocetin-induced platelet aggregation is absent. Platelet aggregation with epinephrine, thrombin, and collagen is normal, and the treatment for this is a platelet transfusion. Glanzmann's thrombasthenia is a rare autosomal recessive disorder. Its symptoms are homozygous. The deficiency or abnormality of GP2B and 3A. It causes the fibrinogen binding to the platelets or platelet aggregation. Variable bleeding patterns with the umbilical cord, gingival bleeding, purpura, prolonged bleeding from minor cuts may be exhibited. Clinical symptoms, you will see a normal platelet count, normal platelet morphology. You will have abnormal aggregation with all aggregating agents except ristocetin. Treatment is going to depend on the severity of the bleeding episode. So if there's excessive menorrhagia, which means you have heavy menstrual cycles, oral contraceptives may be used to eliminate that symptom. And epsilon aminocaproic acid, or EACA, can be used as a topical thrombin-inducing agent, meaning it can be applied to the area that is bleeding. There are also patients that have issues with platelet release defects. These are also inherited disorders. There is abnormal secondary phases of platelet aggregation. It's associated with post-operative bleeding combined with menorrhagia and easy bruisability. However, the platelet count may actually be normal. Hermansky-Pudlak syndrome is a platelet release defect syndrome. It's autosomal recessive. The dense granules are deficient, which we spoke about that in chapter 15, about the alpha granules and dense granules that are in the platelets. It will result in albinism and hemorrhagic events. Shidak-Higashi syndrome is another type of syndrome where there is a defect with the platelet release. It is autosomal recessive. It results in albinism. And there will be giant lysosomal granules in the neutrophils, or the white blood cells. The patient may have frequent infections because of the impaired phagocytic ability of the body with the white blood cells. The platelet release is impaired. The patient will exhibit thrombocytopenia as well as hepatosplenomegaly, meaning that the liver as well as the spleen is enlarged. The Wiskott-Aldrich syndrome is an X-linked recessive disorder, meaning that it will typically be displayed in males or females who are homozygous for that gene mutation. Severe eczema can be a symptom, which is kind of dry, scaly skin that comes up in patches in various places on the body. Recurrent infections, immune defects, and thrombocytopenia. Thrombocytopenia with absent radii or TAR is a rare disorder. That means there are no radial bones. Skeletal and cardiac abnormalities may be seen, and you will also have thrombocytopenia with this as well. Gray platelet syndrome is another type of defect with platelet release. The platelets lack the alpha granules. Previously we talked about the alpha granules when we discussed the different components of the platelets. Platelets are gray or blue-gray in color in the peripheral smear. You will see larger platelets, thrombocytopenia, bleeding tendencies, and bruisability. When it comes to defects of platelet functions, we have extrinsic platelet abnormalities. We have drug-related platelet abnormalities, where aspirin, which is most commonly used, it restrains the COX-1 inhibitors by blocking the formation of the prostaglandin synthesis. It inhibits production of platelet aggregator thromboxane A2. The effects last from 7 to 10 days. Aspirin is often used as a preventative for strokes or heart attacks or other cardiovascular events, so it's used quite commonly. For that, those who are having chest pain, it's recommended to take an aspirin. A lot of times they tell you to keep chewable aspirin on hand if you were to be going into some type of cardio event. You may also see a platelet disorder that is actually secondary to the main disorder, such as renal disease, which can cause purpura, epistaxis, or hemorrhage as far as symptoms go. Uremia, where the thromboxane synthesis is decreased, adhesion is decreased, there's a decrease in the platelet release and a decrease in aggregation. Multiple myeloma and Waldenstrom's macroglobulinemia, where you have increased proteins that cause abnormal participation in the activation of coagulation factors and fibrin formation. And you might also with post-op bleeding and ecchymoses. Patients may also have vascular disorders leading to platelet dysfunction. There might be some sort of abnormality of the skin, of the collagen, of their blood vessels. However, the platelet function and platelet counts are normal. Vascular disorders leading to platelet dysfunction, there are causes that could be mucosal bleeding, which means there's bleeding in areas where there are mucous membranes. Purpura, which are purple spots under the skin caused from bleeding that's right below that top layer of skin. Petechia, it's the same thing, it's caused by the bleeding, but instead of it being a small spot, it's actually pinpoint spots of bleeding. Ecchymosis, which is actual bruising. And telangiectasia, which is elevated dark red blotches on the skin, where the purpura and the petechia are typically not elevated, they're flat. The purpura may be due to infectious agents, amyloidosis, which is where there is a deposits of the protein amyloid in different areas, even within your organs. Vitamin C deficiency or Cushing's syndrome or Cushing's disease or Cushing's syndrome. Here's an example of what purpura looks like. You can see the dark purple where the blood is broken up right underneath the skin. Here is an example of telangiectasia. We also have collagen disorders. We have what's known as Osler-Weber-Rendu disease. It's autosomal dominant. You'll present with small pinpoint hemorrhagic lesions that can occur on the tongue, the roof of the mouth, the palate, on the face, and on the hands. We also have Kasabach-Merritt syndrome, where you can have giant hemangiomas, which are growths of blood vessels that can be found on the liver, the skin, or the spleen. The patient may have bleeding and thrombocytopenia with this condition.